Guys, make sure you sign in to the chat box so you get credit. I do look at these Zoom sign-ins for credit. That was a test. Can you hear me?
Yeah.
Yes, I can
Not
hear
too
you.
bad. It wasn't too
Okay.
bad.
All right, so we're going to start with the digestive system today. You guys know I'm not going to be here tomorrow. For workshop, make sure you are here on. All right, so the digestive system itself goes from your mouth to your anus. It helps you get food, it helps break it down into nutrients. That's called digestion. We absorb those nutrients into the blood, and the body will get rid of anything that is not digestible. There are organs that relate to it. The digestive system eventually eliminates those waste products from food and from any sort of metabolism that occurs in the body. The digestive tract is divided into two sections, the upper and the lower. The upper is your mouth, your esophagus, and your stomach, and the lower is the intestines. Some of the functions, so your mouth obviously takes the food in. That's where the mechanical breakdown starts. Okay. Cells that line the stomach have mucus, hydrochloric acid, and pepsin. And pepsin is what's going to help break down those proteins. The hydrochloric acid provides that acidic environment that the pepsin needs in order to break down those proteins. Your duodenum is the first part of your small intestines. It will get food from the stomach. The food enters the duodenum through the pyloric sphincter, and it enters in small amounts. So the sphincter allows that to happen. And by entering in small amounts, the small intestines can then digest it. Your small intestines is your main area for absorption, and you have to know that. The jejunum and the ileum make up the rest of the intestines. So three parts there: duodenum, jejunum, and the ileum. And you should be familiar with the jejunum because some of you do J-tube feeds. When you do a J-tube feed, that's where it goes. Why do you have to be cautious about medications that you put in that J-tube? Because a lot of them aren't made to be destroyed in that area of the body, but triple them to be crushed and put in there. But read, like, if you just different medications at work and read the directions, okay, for those of you that do tube feeds, I guarantee you that none of them have directions on how to give through a tube. A lot of them are either absorbed in the stomach or the jejunum, which is part of your intestines. But if they're not specifically made to be broken down there, they won't. And you can hear that in the beginning part of this lecture when we're talking about the proteins. There are proteins in your stomach, but in order for you to be able to break them down, you need that hydrochloric acid because that pepsin can't work without it. It's the same thing with certain medications. People will have you giving, you know, G tube and J tube meds all the time. And of course, that is the doctor's call. But always be cautious because there are certain medications that don't break down. And that's why your tubes are always getting clogged or stuck. Plus, the fact that people mix medications that they shouldn't. You're not supposed to be mixing two medications when you put them into a tube of any sort. They should all be given individually. You can mix two strengths of the same medication, but not two different medications. So those parts of the small intestine, the jejunum and the ileum, the duodenum, these are all responsible for absorption of fats and nutrients. But remember the ileus, okay? That is your main, or that ileum, that is your main place for absorption. All right, so this slide is just telling you the different parts and what they do. Digestion starts in the mouth, the esophagus, that's going to bring the food to the stomach. The stomach stores and breaks down the food using acids and enzymes. Your small intestines then absorbs those nutrients. The large intestines is going to get rid of whatever else we don't need, but it also helps absorb water. So it's going to form that stool into feces. It's going to help you absorb water. The liver provides bile, and that bile helps break down the fats. Now, the gallbladder is where that bile is stored for the digestion of the fat. So that's why when people don't have a gallbladder anymore, it's not just that um, fatty fried foods affect them when the gallbladder is going bad. Why does it affect them when the gallbladder is going because if the gallbladder has slush and stones and all this gross stuff in there and it's not really working, because a lot of times when people get it out, it's already necrotic. So that means it's not really properly using that bile. And so when they eat these fatty, greasy foods, they get sick or they have diarrhea. And when they get the gallbladder out, they'll still have some of those symptoms because they don't have that bile to go in there and break down that fat and help absorb it or help the body use it. The pancreas puts out enzymes. Those enzymes are going to break down carbohydrates, proteins, and fats. Your rectum stores the stool before we eliminate. And then the anus, of course, is the place where it exits out of. So that's just another diaphragm showing you the entire events that we just talked about. So things that you have to know is where does the digestive system start? And that's in the mouth. And that's that amylase, okay? Salivary amylase is going to be secreted there and start to break down the food. Your esophagus is a tube, okay? It goes from your throat down to the stomach to bring the food down there. In that stomach, you'll have a mixture of things there, one of them being chyme. So chyme is part of what's going to make that bolus so that food can be transferred. It's also going to help break down some of the stuff that is there. You have gastric secretions, digestion protein, the intrinsic factor, acid. And then in the small intestines, you'll have bile that emulsifies the fat, those pancreatic secretions we talked about that we're going to help break stuff down like lipase. You have secretions there that will help digest the fat, the protein, and the carbs. Again, those are coming from the pancreas. And then your nutrients are going to be absorbed. You notice that says small intestine there in that ileum. That's where those nutrients are absorbed. And then your colon is going to absorb the water and the electrolytes, make that feces, and get rid of it. Any questions on any of that? You got to know that part. All right, and then in your stomach, or some people call it your gut, you have your mucosa. Now, the mucosa is really to protect. Okay, there's a lot of acid, there's a lot of enzymes there, and we need those enzymes and that acid to work on other things, like helping us absorb that B12 or helping break down that food. So we don't need it to penetrate the lining of the stomach because then people develop things like an ulcer. So you have a couple different areas there, mucosa, submucosa, some smooth layer, smooth muscle layer. You know, in smooth muscle, usually action happens there. So maybe like peristalsis and other things that help with digestion. You also have your peritoneal cavity there, guys, and that is just the space between the parietal and the visceral peritoneum. There's a certain amount of serous fluid in that cavity that helps with movement of different structures in the stomach. That area can become inflamed sometimes, peritonitis, okay? Especially if your bowel were perforated or if your appendix ruptured and fluids or bacteria went in there that are not supposed to, it can become very irritated and you can develop that peritonitis. You got to know what that is. We'll talk about that at some point. But these people, the blood pressure is going to drop. They're bored. Their stomach becomes board like. I mean board like. It's hard, rigid. Okay, it's very painful. So they become tachycardic, sweaty, low blood pressure. All right, so now we're going to talk about the upper GI tract, the oral cavity, the esophagus, the stomach. I'm not sure who spelled stomach on there. The spelling looks like some of the words that come out of my mouth. All right, oral cavity. This is where that mechanical breakdown starts. Your teeth chew it, or we call mastication. Again, that salivary amylase is going to start to break down the carbohydrates there. There's going to be a bolus there. Those salivary secretions come from glands in your mouth called the parotid, the sublingual, and the submandibular. And those come in through the salivary ducts. They help moisturize and lubricate the food so that the food can move through the esophagus. And then the amylase, that's going to start that digestion process of carbohydrates in the mouth. That is called salivary amylase. You also have pancreatic amylase. Okay, this one's called salivary. So your tongue actually pushes that food back once it becomes a little bit of a bolus or like a little ball of food at the back of your tongue. All right. And then your reflexes activated at that point. Swallowing then becomes an involuntary action. And the swallowing center will coordinate the actions to move the food or the fluid down into the stomach. And it does that without you aspirating, okay? And that's because your airway is going to be blocked, hopefully. Sometimes when we're talking or, we do something, we're not paying attention when we're eating, the food goes into the airway and then it can go into your lungs, but it is supposed to go into the esophagus. Some people also may have some issues, some aspiration issues. So with them, you usually know, right? How do you know when one of your clients has an aspiration issue?
Are choking?
Okay, but they'll usually give subtle signs first.
Coughing?
Often, especially when
During meal?
liquids. A lot of times they'll cough when they're drinking liquids. And so when you notice that, you should have speech evaluate. I'm not saying if someone does it once or twice, but these people will cough. If you notice you have some people you give meds to, every time you give them their meds and they go to drink, they're coughing, coughing. All right, so that's worth checking out. But there are some other things that you'll see, like choking, gagging, okay, or they'll just tell you, I can't swallow it, I can't get it down, or they'll actually aspirate. So a couple of cranial nerves will help with the swallowing mechanism, and that is 5, 9, 10, and 12. Those all work together to coordinate that activity. So hopefully it goes where it's supposed to. All right. And that's just the oral cavity. What do you really need to know about that? What I already said. Okay. There's some glands there. They're secreting that fluids to help lubricate the food. Okay. And you have amylase that's secreted there to help break down the carbohydrates. That esophagus is made out of skeletal muscle and smooth muscle. Okay. So remember, smooth muscle is always going to help with some kind of action. It's also lined with mucus and it's closed when you swallow. Cranial nerves 5, 9, 10, and 12 help with the swallowing mechanism. All right, so once you do that mechanism, the epiglottis there will cover the larynx. You'll swallow that food, the bolus will get it, it'll move that food into the esophagus, and that peristalsis starts to move the food down the esophagus. And then at the end of the esophagus, the food will pass through the hiatus. The hiatus is the opening into the diaphragm to join the stomach. The lower esophageal sphincter will relax, and that allows the food to go in the stomach. So when someone has GERD, okay, this lower esophageal sphincter does not work right. That lower that lower esophageal sphincter helps keep the gastric content in the stomach. If it goes into the esophagus, then it causes damage, erosion. They also call this because nursing can never have one name for anything. They call this the gastroesophageal or the cardiac sphincter. But I'm pretty sure for you guys, for the exams and everything, they call it the lower esophageal sphincter. You'll also see it abbreviated as LES, lower esophageal sphincter. Okay, so when this doesn't work, when you think about a sphincter, think about something that allows something to go through it and then it closes so that it can't come back. Okay. So it's allowing things to go through it, then it closes so it can't come back. Pressure in the sphincter prevents the reflux of the gastric content back into the esophagus. Now, the stomach, it's a muscular sac. It's able to expand. It serves as a reservoir for food and fluid. It can hold a pretty good amount, about 1.5 liters of food and fluid. When it's empty, it falls into folds or rugged. And all this means, these folds or this rugged to expand or get bigger. So when you eat a meal, if you ever notice, sometimes your belly looks a little puffy after it, especially when you do like me and overstuff. Okay. So something's good. A lot of times I find myself eating too much of it, and then you're like, oh man, I ate too much. And the belly's a little puffy because it can expand a little bit. This happens sometimes to people that have gastric bypass. Okay. They get the gastric bypass and they think, okay, I got the surgery. I'm good to go. I'm going to lose weight. But you won't if you keep stuffing food in your mouth because you still have to break those habits. And what'll happen is the stomach will just stretch back out again. And before you know it, you'll see somebody who was doing really good for a year or two. And now all of a sudden, you start to see that weight go back on. That's why I say it's the worst drug of choice. Food is the hardest thing to avoid because everybody uses food for everything. You're sad, let's eat. You're happy, let's eat. You're in the middle, let's eat. I'm stressed, let's eat. The baby's crying, feed them. The kid's crying, feed them. Even our kids are obese because that's what we do. Shut them up, we feed them, we stick the electronics in their hand. So the wall has the stomach wall has three smooth muscle layers, and they have the mucosa and the submucosa. Now, the mucosa helps prevent any penetration of the acid or the pepsin. And it's also constantly being mixed and churned there. Secretions come in from the gastric glands. Gastric glands that secrete those secretions are helping to maintain the gastric content in there. So those secretions that are coming from those gastric glands are going to help dilute the gastric contents. And it makes that chyme. which is like a creamy material, and that starts the digestion of protein. The gastric glands in the fundus of the stomach have parietal cells. Talked about these already when I talked about the pernicious anemia. The parietal cells secrete hydrochloric acid, and the chief cells secrete pepsinogen, and I would know that. Okay, parietal cells secrete hydrochloric acid, chief cells secrete pepsinogen. Pepsinogen is going to be converted into pepsin. And remember that pepsin is breaking down proteins. Hydrochloric acid is also needed for that. The intrinsic factor that is required for absorption of B12 in the ileum, because in the ileum is where most of your absorption takes place, is also produced by the parietal cells. So the parietal cells secrete hydrochloric acid and intrinsic factor. Chief cells secrete pepsinogen, will eventually become pepsin and break down your proteins. Got it? The gastric secretions are a defense mechanism in the body. Okay, they're highly acidic, so they can destroy things like microorganisms that try to come in from the resident flora in the mouth, or from your fork, or from the food itself. Mucus is secreted from glands there. All right, and that mucus is going to help protect the stomach. And enteroendocrine glands also secrete chemicals. The most important one is gastrin. So whenever you take in things like food into your stomach, that gastrin is released. That gastrin is going to stimulate parietal cells and the chief cells. Parietal cells are going to release what?
Hydrochloric acid and chief cells.
And intrinsic factor, hydrochloric acid and intrinsic factor. And the chief cells are going to secrete
Pepsinogen.
pepsinogen, okay, which is going to turn into pepsin. So think about Pepsi, okay? And Pepsi, okay, is going to help do what? Break down the proteins, okay? So it depends on the food ingested on how quick the stomach will empty. You have about 1 to 3 mLs of chyme that are passing through the pyloric sphincter into the duodenum. Remember, I said these pyloric sphincters, they allow stuff in, but they don't allow stuff out. What they're supposed to do.
Excuse me, Professor Loge. Are you changing the slide?
So, no, we're not there yet.
Okay.
So that pyloric sphincter is just allowing small amounts of food to go into that duodenum, okay, so that it doesn't overload it. And these small amounts are then broken down and absorbed as needed. There's also secretions from the liver and the pancreas. Now, the pancreas we already learned about in endocrine function, but it also has exocrine function. Okay, so it's going to secrete things that are added to the chyme. There's also small things, small lipid molecules like alcohol. Now, for alcohol, this process doesn't have to happen for you. Okay, when you drink alcohol, it goes right into your body, into your bloodstream, because it can easily be absorbed through diffusion. So, what does that mean? So, what do your parents always tell you when you're going to go out to drink?
Eat
Eat
something.
something.
eat something, right? Because it delays the absorption. College kids don't have money. If they don't have money, what are they spending it on? Food or alcohol?
Alcohol.
Alcohol, right? Because if you're drunk enough, you don't need food. That's their theory. Um, so they drink the alcohol, okay, it absorbs quickly into the bloodstream, and then we're at like these frat parties or whatever, and they do some shots. Okay, remember it can easily pass into the brain as well, alcohol. So now they've drank like let's say 7 or 8 shots, but it's really strong alcohol. Like your Everclear and stuff like that, that's like 190 proof. That's a very strong alcohol. 7 shots of that, and it goes into your bloodstream without you eating and into your brain. It can actually kill you. So that's why you see them dying from alcohol poisoning because it's so easy to absorb. But if you eat food before you drink, while you're drinking, and after you drink, it doesn't affect you as badly. You still get loaded off of it. Okay, don't get me wrong. It's not going to happen as quickly, and usually you won't get as sick from it. All right, so in your liver, you have something called a hepatic portal system. And most of your blood from the abdomen or the organs in the abdomen go into that hepatic system. Okay, the nutrient rich blood from your digestive organs, from your spleen, is delivered to hepatocytes. Now, hepatocytes are just your liver cells. Okay, after processing, blood is delivered into the IVC using the hepatic veins. So your IVC there is your inferior vena cava.
I'm not locking the door, by the way. I don't have
Please
my
put
key.
yourself on mute. To the liver, we have deoxygenated blood, and deoxygenated blood can have nutrients and toxins in it. So, of course, the liver is going to help remove some of
Hey,
those
Mom.
toxins from the blood. Okay. So the liver is help doing that, and then it's going to put that blood back into circulation. I just need to make something here a little bit bigger. Let's see if I can read it. Right, so the nutrients are broken down into simple molecules, and they're going to be absorbed with electrolytes and water into the blood, and they're transported into the liver. So they go into that hepatic portal system I just talked about first, and then into the liver. Okay. And then the liver cells will drain the blood back into general circulation and into the inferior vena cava. This helps to bring oxygen to the cells in the liver and into the hepatic portal system. And then the nutrients that are absorbed from the stomach and the intestine are able to get back into circulation. So what it's doing here is just sending things through that hepatic portal system and that liver so that toxins can be removed. You also have Kupffer cells there. You should know what those are. That's spelled Kupffer. Those Kupffer cells help remove and phagocytose any foreign material and bacteria from the digestive tract before the blood goes back into circulation. Nutrients are absorbed there by the liver cells. So iron, copper, vitamin A, B12, B6, vitamin D, vitamin K, folic acid, all taken up there. Things like iron or amino acid are monitored by that system there. Okay, so the body will try to replace them. Blood glucose levels are maintained there. So besides insulin, the liver also can respond to high levels of blood glucose through glycogenetic, can't say it, by glycogenesis. Okay, so what it does is converts the glucose into glycogen and it stores it in the liver. The liver cells can also break down glycogen into glucose if blood glucose levels drop, and glucogen secretion would then increase in order to maintain your blood sugar. Of course, in people that have diabetes, this process doesn't always happen well. Gluconeogenesis is the formation of glucose, and that will take place when glucose levels drop under the influence of hormones like cortisol and epinephrine.
Okay, give me that because that's not for you.
Could you
What you put
please
on your
put
list?
yourself on mute? Did you hear me, young lady? Let me just double check this student's microphone. Sorry, guys. Of course, I can't find it. Well, hopefully we don't have that issue again. All right. We were talking about how the liver is removing different stuff in the body, okay? And how it's cleaning it, taking out any nutrients that it needs, putting them back into the bloodstream, removing any toxins. It'll also absorb some of those vitamins. It'll help maintain your blood sugars through gluconeogenesis. Okay, it also helps to regulate your clotting, your proteins, your lipoproteins. It helps to synthesize cholesterol when the body needs it. So we use cholesterol for things like making steroid hormones, cortisol, and sex hormones, as well as biosalts. And those biosalts help with the bile and help with the breakdown of the fats. The aldosterone and estrogen are inactivated at the liver and they're prepared for excretion there. The liver also removes ammonia from the body. And that ammonia is actually called nitrogen in the body, and it comes from the metabolism of the protein in the intestine or the liver. Drugs and alcohol are detoxified here before they're excreted out of the body. Damaged or old red blood cells are also removed from the blood to help with the recycling of the iron and the protein from the hemoglobin. The liver is also like the spleen in the fact that it's a blood reservoir. Okay, it's capable of releasing large quantities of blood in general circulation. So if you blood levels were to fall for some reason, the liver can actually help resupply some of that. The cells in the liver, again, are called hepatocytes. That is where bile is produced. Now, bile is important for the body. It helps with digestion and it helps remove bilirubin. And we've already learned about bilirubin, right? Excessive amounts of bilirubin in the body we don't like. It also helps remove any excess cholesterol from the body. Bile salts themselves are made from cholesterol, and these help us with emulsification of fats. absorption of those fat soluble vitamins. Those are A, D, E, and K. I call them A deck. That's how I remember them. They can be
Miss Lawrence,
absorbed.
Miss Lawrence, whatever you're saying though, we only have this liver slide up here.
I understand that. That is where the notes are coming from.
Okay.
Because this is what we're talking about, the liver. Thank you.
You're welcome.
Right, so the liver is helping absorb all these vitamins. Okay, so these are all the things. Liver is responsible for a lot in the body. Okay, and you're seeing how this is what I'm talking about is how the liver detoxifies the food because that food has bacteria in it. You're taking into the body has a certain amount of bacteria in it, and so the liver is going to help protect you against that. So again, the blood's going to go through the hepatic portal system and then into the liver where it's detoxified, and then it'll either go back into circulation or into the inferior vena cava where it will be removed from the body. All right, now we're going to talk about the pancreas. The pancreas secretes digestive enzymes, electrolytes, and water. Those drain into a main pancreatic duct, and that duct will carry secretions from the pancreas into the common and into the duodenum. Remember, in the duodenum, that's where things are going to start to be broken. Now, in addition to that, we were talking about cystic fibrosis. And so with people with cystic fibrosis, these ducts that are coming out of the pancreas are blocked. And that's why their stools are fatty because they're not producing those enzymes. They're not going into the duodenum there and they're not breaking down those fats so the body can absorb them. So that's why if you're treating someone with cystic fibrosis, you have those little capsules that you have to open up and put into the food because those pancreatic enzymes they should be producing naturally, not able to get to where they're supposed to. Now you have to know these enzymes. So trypsin, chymotrypsin, carboxypeptidase, those are the three. Pancreatic amylase is another one. This helps to digest the carbohydrates, and the lipase will help digest. Enzymes are then secreted in the inactive form. Okay, so they're not activated until they actually enter the duodenum. The pancreatic cells produce trypsin inhibitor. Okay, that trypsin inhibitor prevents the pancreas from activating inside from it prevents the enzymes from activating inside the pancreas so they don't eat up or destroy the pancreas. Pancreatitis, that's what's happening. Okay, the enzymes are attacking the pancreas. Pancreatic secretions have bicarb ion. You have to know this. The bicarb ion is going to neutralize the hydrochloric acid in that duodenum. In the small intestines, you have three sections, the duodenum, the jejunum, and the ileum. So the contents will mix and move through there slowly. Remember that pyloric sphincter is going to let it come in there very slowly. As that happens, enzymes are added. The ileum is where most of the nutrients are absorbed. Small intestine will have villi and microvilli. And these are little finger-like projections that help increase the absorption area and help suck up the nutrients. You also have in those villi a capillary network, a lacteal, which is a little duct or a terminal for the lymphatic vessel, and that helps it to absorb lipids. And then at the base of the villi, you have these little crypts or pockets. And that's where the new epithelial cells come from. They help activate the pancreatic enzymes and the hormones, cholecystokinin, I would know that one. Other enzymes produced in the intestinal mucosa include peptidases, nucleosidases, lipase, sucrase, maltase, and lactase. So you might have heard about some of those in nutrition. You have goblet cells there in the mucosa. Those help to secrete mucus and protect the intestinal wall and buffer it from that acidic chyme. In the ileum, in the small intestines, there's large patches of lymph tissue. These are called Peyer's patches, and they help limit the resident bacteria. So they provide an immune response against those resident bacteria to prevent the small intestines. I'm sorry, to protect the small intestines. All right, so some of these we already talked about. These are your major digestive enzymes. Salivary amylase in the mouth, that starts the digestion of what?
That's
Carbohydrates.
carbohydrates.
Okay. Your pepsinogen, which is released by the gastric chief cells, that helps produce pepsin, and pepsin breaks down
Protein.
protein. Okay. Then your pancreatic enzymes, okay, you have amylase and lipase. Lipase is going to help break down the fats. The amylase is going to help break down the carbohydrates. Then your trypsin, your chymotrypsin, your carboxypeptidase, these help to break down your peptides by splitting your proteins into the peptides. You have intestinal lipase that helps convert your fats into fatty acids and glycerol. And then you have intestinal sucrase, maltase, and lactase. These help convert your sugars and break those down. Okay, so they're breaking down those complex sugars like disaccharides into more simple sugars, monosaccharides. The ileocecal valve is where the entry point is from the ileum into the large intestine. So if you move down the intestines from the top, from the cecum is the ascending colon, which becomes the transverse colon. That passes down the left side and becomes the descending colon. It's kind of important to know where these parts of the colon are, because if you're taking care of somebody that has ostomy, okay, depending on where that's located, what sort of stool or out you would expect to see there. Like if it's a sigmoid ostomy versus an ileostomy. All right, so it terminates at the sigmoid, colon, the rectum, and the anal canal. Absorption of large amounts of water and electrolytes take place in the colon. This helps maintain your fluid balance and your acid-base balance. Digestion and absorption of nutrients stops in the colon. Bacteria, resident bacteria that you have there will help to break down certain food materials and convert bilirubin into urobilirubin. That gives the feces the brown color, bilirubin to urobilinogen. And that makes the poop brown. Other bacteria that helps are vitamin K, which is synthesized there. We need that for clotting. Prothrombin, fibrinogen in the liver. Large pouches in the colon allow for expansion. And feces is made mostly of fiber or other things that are considered indigestible. There's also some mucosa in it and some bacteria. So increased bulk in the intestines, increased intestinal motility, and the rate of passage make for a larger fecal mass and more frequent defecation or bowel movements. The rectal wall itself will distend, and that stimulates the defecation reflex. The small intestines, again, this is where digestion and absorption is going to occur. Stimulation of the parasympathetic nervous system through the vagus nerve, cranial nerve 10, causes an increase in motility and an increase in secretions in the digestive system. So rest and digest, that's parasympathetic nervous system. During the initial cephalic phase, before you eat, pleasant smells or the thought of food affect the parasympathetic nervous system. So how many of you know about Pavlov's dogs? Any of you?
Can you repeat your question? I'm sorry.
Yeah, how many of you know about Pavlov's dogs?
I've heard of it, but I don't know it.
So there was a scientist, and his name was Pavlov, and he was trying to prove different things about the body, right? So he had this group of dogs, and what he would do is he would set food out and he would ring a bell, and the dogs would come running and they would eat the food, right? Then he would start doing simulations where he would just ring the bell, feed them all. And the dogs would come and they would have Miss Mazzola. Can you hear me? Miss Mazzola,
I answer your question. Maybe you didn't hear me.
what's
I
your
said we all
question?
when you asked if we fall hard about Pavlov, I said yes in lifespan.
Okay, but I hear you talking in the background. You're talking to your kid or somebody in the background, and it keeps coming on the recording. So when you talk, put yourself on mute. When you want to press the space bar, that will take you off of mute. Do you know where the space bar is? So that we don't hear your background noise. That's all I'm asking, okay? Thank you. So Pavlov's dogs, what would happen is after a while, he would just ring the bell. And the dogs would salivate, okay? Thinking that food's there. So their body would start to produce this natural symptom. And this is what this is saying. Whenever you smell the food or you see the food, that starts that parasympathetic process. Now, other proof of this is let's talk about Thanksgiving dinner. What happens when you cook Thanksgiving dinner and it's time to sit down and eat?
You may not be as hungry.
Yeah, you're not hungry.
You're full. You're like, I don't even want to eat. And you really haven't been tasting the food. I mean, you've taken a touch here or a touch there just to make sure that the seasoning's right. I don't really eat a lot of food. Those smells. It's It's the most marvelous thing, right? To wake up on Thanksgiving morning or Christmas morning and smell the house with that food. And that triggers that parasympathetic nervous system stimulation. And emotions like fear or anger, your sympathetic nervous state. So what happens is when you're in fight or flight, um, your nervous system is going to kick in, and that's going to stop you from salivating. It's going to cause vasoconstriction there. Okay. So those processes of what you would normally do there stop. Your gastrointestinal activity is going to be hit or limited. So you have vasoconstriction, reduced secretions, regeneration of those epithelial cells. All right, you should know what these things do. We talked about gastrin. So whenever you put food in the stomach, or if you drink caffeine, protein, and smoking cigarettes can also cause increases in gastric secretion and motility, and it promotes gastric emptying. Cholecystokinin, this is going to come from your mucosa cells. It's stimulated by any protein or fat in the duodenum, and it inhibits gastric secretions. It stimulates the pancreatic enzymes because now the stuff is in the duodenum. We want to break it down. It stimulates the gallbladder. And so now the gallbladder can release bile to help break down that fat. Then you have secretin also coming from the mucosa cells. It's stimulated by that acidic chyme in the duodenum. The secretin will stimulate the bile and the pancreatic secretions. Remember, those pancreatic secretions are high in bicarb content. I would know that. So secretin is going to stimulate those high bicarb and bile. So you want to know these three and the other ones I told you about. The parasympathetic nervous system, that taste or that smell of food will stimulate it. So that's going to increase your secretions, increase peristalsis, so that the food can be broken down and used the way it needs to. In sympathetic nervous system or stress, okay, most of us aren't eating anyway. So this is going to decrease your secretions, decrease your peristalsis, and cause vasoconstriction in the mucosa. That's where the
Miss
stain
Lodge, I
comes.
have a question. I have a question because
Yes.
this happen differently to different people. Because like some people when they're stressed they eat a lot. For others when they're stressed they don't eat a lot. So how does that
Whether you eat a lot or not, it's not saying that it decreases your appetite.
okay.
It's saying it decreases the way the body works.
Oh, all right, thank you. I get it now.
Good question. All right. So now we're going to talk a little bit about some of the controls there. Okay, so the facial nerve and the glossopharyngeal nerve. The facial nerve is cranial nerve 7. The glossopharyngeal nerve is cranial nerve 9. And these are going to help with controlling that parasympathetic nervous activity. Come on. Sorry, my other computer is frozen. It's not. I don't understand. Guys, give me 1 second. Okay, so using that facial nerve, cranial nerve 7, and glossopharyngeal cranial nerve 9, sympathetic nervous system maintains a continuous flow of saliva in the mouth. That helps keep everything moist. It helps with cleaning. It helps with you being able to talk so that your mouth is not too dry. If you were to have a dry mouth for any reason, then that would cause that sensation of thirst, and that is supposed to help protect you against dryness in that mouth. The sight, the thought, or the presence of food in the mouth stimulate any increased salivary secretions, and the secretions will usually continue for a long time after you swallow, and that helps to clean out the mouth. When food reaches the stomach, it will distend or stretch, and the increased pH caused by the food intake will activate your parasympathetic nervous system. That will increase peristalsis, increase the gastric secretions. The peripheral nervous system will also increase the bile, increase pancreatic secretions. Depending on how much food or the type of food you ate, the stomach will empty in about 2 to 6 hours after you eat. The fluids will move quickly, the fats will move slowly. Presence of food in the intestines will stimulate intestinal activity but inhibit gastric activity. And that prevents overload of the duodenum, and it gives it enough time so that digestion and absorption can occur. Remember, in someone that has dumping syndrome or short bowel or short gut syndrome, their body can't do this process of absorption. Food will pass through that small intestine at a pretty constant rate. After eating, a reflex and peristalsis around that ileocecal valve will occur, and that moves that ileal content into the cecum and then the colon. You have a reflex there called gastrocolic reflex that will stimulate a mass movement of the material that's in the colon into the rectum when food enters the stomach. Now, hormones play a major role in the process of indigestion. Digestion and absorption. Gastrin is secreted by the mucosal cells whenever the stomach distends. So usually when something enters that stomach, like partially digested protein, alcohol, caffeine, gastrin enters the blood, and then it'll stimulate the gastric cells to increase secretions, increase gastric motility, relax the pyloric and the ileocecal sphincter, and that causes the stomach to empty. Histamine from histamine 2 receptors are released from the mast cells, and that causes an increased secretion of hydrochloric acid. When the chyme enters the duodenum, the mucosal cells will then release that secretin and that cholecystokinin. The secretin will decrease gastric secretions, and increased bicarb from the pancreatic secretions and bile, especially when the chyme is very acidic. Cholecystokinin will inhibit gastric emptying, stimulate the pancreatic secretions with increased digestive enzymes, contraction of the gallbladder, increase bile to the blood. And remember that bile is needed to break stuff down. Right, so that was the slide I was just talking about, the hormone controls. Any questions about that? You got to know these and how they work. So nutrients broken down and absorbed along with electrolytes and water into the blood, transported to the liver through the hepatic portal system. Complex carbs like starches, digested first in the mouth and then in the intestine. The body uses active transport. Okay, so healthy cells have a good blood supply. Proteins are split into peptides. These are short chains of amino acids. You should have learned about all that in nutrition. In the stomach and the intestines, and then they're broken down into what we call peptidases, very actual amino acids, and then absorbed in the small intestines. Lipids are fats, mostly triglycerides, have to be emulsified first. The bile does that with the bile salt. That happens in the small intestines. The enzymes then act on the fats to form monoglycerides and free fatty acids. This allows them to then be able to move across the membrane. The lymphatic capillaries in the intestinal villi will absorb and transport these lipids as chylomicrons. And you guys have seen that term before. We talked about these little chylomicrons and how they're transported a little bit when we were talking about lipids and cholesterol in the body, doing cardiac and things like that. A chylomicron is just a lipoprotein that carries triglycerides in the blood during fat digestion. The bile salts are formed from cholesterol. They are necessary in order to emulsify the fats. And that helps the body with the fat-soluble vitamins. I said I call ATEC, they are ADEF. So in order for those vitamins to be absorbed, we need that bile. Water-soluble vitamins like B and C and your minerals like iron, copper, and zinc go into the blood through diffusion. Electrolytes like sodium, potassium, chloride, bicarb are absorbed through active transport or diffusion into the blood. Drugs are primarily absorbed in the intestine. Some of them, such as aspirin, can be absorbed in the stomach. Other small molecules can be absorbed through the oral mucosa. Some drugs are broken down by digestive enzymes. Large amounts of food in the stomach and the intestine can delay absorption. So this is why certain drugs you have to give apart from food or other things. Presence of food or drugs, such as antacids, can interfere with absorption of other drugs. Water is absorbed by osmosis. About 7,000 milliliters is treated into your digestive system every day. And about 2,300 of that comes from food and fluids. Of this amount, only about 200 mLs will leave the body in feces. So somewhere between 50 and 200. If someone has severe vomiting or diarrhea, it can interrupt the recycling mechanism, and it can disturb or disrupt the fluid and electrolyte balance in the body. Common manifestations of the digestive system include things like anorexia, nausea, vomiting, bulimia, diarrhea, constipation, fluid and electrolyte imbalances, pain, and nutrition. Now, you are going to have to know the difference for sure between anorexia and bulimia. You should already know the difference between diarrhea and constipation. So, any sort of anorexia, nausea, vomiting, or bulimia can be a sign of a digestive disorder. Sometimes they can have nausea or anorexia because of infections in the system, uremia, which would be a problem with their urine, emotional responses. So sometimes when you're anxious, you'll vomit or you'll have diarrhea, right? You have bubble gut. You need to take a test, you got anxiety, run to the bathroom. Motion sickness, too much pressure in the brain. So ICP, eating too much food or taking too many drugs and pain. All these can cause these symptoms. Manifestations of anorexia, nausea, and vomiting are the signs of a digestive system disorder or some other condition. Anorexia will usually happen before nausea and vomiting. Vomiting is also considered a defense in the body. It helps remove anything that's noxious or undesirable in the body. In addition, anorexia and vomiting can cause serious complications like dehydration, acidosis, and malnutrition. Anorexia often will happen before the nausea and the vomiting. Nausea is an unpleasant subjective feeling, and it can be stimulated by distension, irritation, or inflammation in the digestive tract. It's also stimulated by things like smells, visual images, pain, chemical toxins, and or drinks. The vomiting center is in your medulla, that's in your brainstem. It coordinates vomiting and activity that are involved. So this is why if someone has increased cranial pressure, it presses down on that brainstem, and that causes you to have that exorcist type of vomiting that's not associated with food. The body will close off the glottis and try to protect the airway when you vomit. That's to prevent any sort of aspiration. If you were to aspirate the vomit in the lungs, it could cause inflammation or obstruction of the airway. Vomiting or emesis is forceful expulsion of chyme from the stomach. And sometimes it also includes things like bile from the intestine. Bulimia is an eating disorder. In bulimia, the client will binge and overeat. So, like, they'll go in the kitchen and just start stuffing the face. Okay. The problem is afterwards they'll vomit and they force themselves to vomit, or they'll take laxatives, or they'll starve themselves because they don't want to gain weight. Clinically, it's considered a behavioral disorder. Okay, but because they have the disorder, it causes problems with the digestive system. So it can cause damage to the oral cavity or the teeth, okay, because the vomiting causes acid to wash up against that and lay on those teeth. In addition to visible damage to the structures of the oral cavity, it can cause tears in the esophagus, constipation, diarrhea, electrolyte or nutritional imbalances and deficiencies. Now, usually with bulimia, there'll be a normal weight or slightly sometimes even overweight. They're not usually skinny like people with anorexia are. So they'll ask you about that possibly, and they'll ask you about damage, especially that damage to the teeth, the oral mucosa, excessive vomiting. The vomiting center itself is activated by things like distension or irritation in the digestive tract, stimuli from certain parts of the brain in response to some unpleasant sight or smell, or ischemia. So, like someone's having a stroke. Pain or stress, motion sickness, stimulation of the chemoreceptor trigger zone in the medulla by drugs or toxins, increased cranial pressure, which I just talked about, it causes sudden projectile vomiting without any intake of food or nausea. So that could be a test question. I wouldn't be surprised. Again, it's because the fluid from the brain is putting pressure on that emesis center, which is located in your medulla at the brain stem. Sometimes people can have retching before the vomiting. So that's like you're gagging, where you're trying to throw up and nothing's really coming out. The vomiting reflex involves involuntary activity. Okay, when it happens, I'm not going to go through the whole steps. I don't think they'll ask you about that, quite honestly. Probably more about understanding like what those different enzymes do in the body that we talked about. You should know what the vomiting reflex is. It's an involuntary action that happens there, okay, from increased pressure in the stimulus to the vomiting center. And you have increased pressure with the chyme that forces that chyme up and into the mouth. Okay. You have usually hypersalivation. So, usually, when this vomiting process is going on, you're secreting a lot of saliva. A lot of times, you have pallor, sweat, tachycardia from vasoconstriction. Okay. Your vomiting center, that is in your brain. Okay. So, the cranial nerves, remember, come right through there, that part of your brain. Cranial nerves 5, 7, 9, 10, and 12. So when that stimulation occurs, that hypersecretion, your glottis is going to close off so that the food doesn't go in your airway. All right. And then eventually your sphincter will relax there. You'll have peristalsis that's going in the opposite direction now. Your abdominal muscles are forcing that peristalsis or those contractions. And when that increased pressure hits, again, it's going to force that stomach content, that chyme up and out of your mouth. A lot of times people will retch a bunch of times first and then they'll vomit. The vomiting itself can be exhausting and painful because there are strong muscle contractions that cause that area to move or force the food up. This can be especially painful when there's no food or nothing to vomit. If the client's unconscious, they're at risk for aspiration. So typically we're going to put them in a recovery position. They're heavily sedated. Okay, so we put them on their side so that way it doesn't, aspirate. They don't aspirate on the vomit. Blood in the vomitus, resembling coffee grounds, emesis, brown granular material from partial digestion. This is from proteins in the blood. If the client has a hemorrhage, then you would see red blood in the vomit. Blood is foreign and it irritates the gastric mucosa. Yellow or greenish stained vomit usually indicates some kind of bile from the duodenum. If it's a deep brown color, that can be from the lower intestines. We usually see that in a bowel obstruction. So if you ever had someone that with fecal matter coming out of their mouth, or this brown stuff, or sometimes you can just see a little bit of the brown, but their mouth smells like fecal matter. You should consider having them worked up for bowel obstruction. Recurrent vomiting of undigested food from previous meals indicates some kind of problem with gastric emptying, like pyloric maybe is obstructed. Diarrhea, we have too many stools. They're usually loose or watery. Sometimes people have soft stool and they call it diarrhea. It's not really diarrhea. Usually diarrhea is going to be loose or watery, not just soft. It can be acute or chronic, and it can be accompanied by nausea and vomiting, especially if they have inflammation or infection of the digestive tract. Diarrhea sometimes will be accompanied by cramping pain. Severe or prolonged diarrhea can cause dehydration, electrolyte imbalances, acidosis, malnutrition. Also, look at the stool. Is there any blood, mucus, or pus in it? That can help us diagnose. So diarrhea diseases referred to as enterocolitis. Large volume diarrhea is osmotic. Think about it when I said the same thing about the large amounts of urine. They're osmotic because so many large particles in there. So large volume diarrhea, the same thing. Osmotic, it causes a watery stool. And usually this is because of increased secretions into the intestine. It can be related to infection. It can be because of some sort of reabsorption issue. And it will cause problem with reabsorption if it moves too quickly. It'll cause a problem with being able to accumulate those electrolytes that we need back into the body. That large volume diarrhea also prevents the bowel from absorbing the correct amounts of water and electrolytes. And that can cause even more watery stool. Common cause of osmotic diarrhea is lactose intolerance. The lactose remains undigested and is not absorbed inside the intestine, and that increases the osmotic pressure of the contents. Sometimes it's because of a carbohydrate issue. The body does not absorb certain carbohydrates efficiently. This can cause the food to draw water into the intestine. and that can cause osmotic diarrhea. This can happen if the person has intolerance to carbohydrates like lactose, maltose, sucrose, or fructose. It can also occur in digestive orders like celiac disease. Some medications cause osmotic diarrhea. Some laxatives that we give, that's the effect that we want from them, and that's why we're giving them. Small volume diarrhea usually occurs in inflammatory bowel disease, and these stools may have blood in them, mucus, or pus. Diarrhea might be accompanied by abdominal cramps or a sense of urgency. Steatorrhea is fatty diarrhea. So we'll see this a lot with cystic fibrosis or celiacs. It's what we consider bulky, greasy, loose stools. Most of the time, they don't smell very good. They have a foul odor to them. These stools are characteristic of malabsorption syndromes like celiacs, cystic fibrosis. Here, the intake is not digested or absorbed. Fat is usually the first dietary component affected, and the presence of fat interferes with digestion of other nutrients. The abdomen will be distended. Because of the bulk in the intestines. Malnutrition is apparent in other tissue unless disguised by edema caused by low protein levels or hypoproteinemia. Sometimes we'll see blood in the stool. Blood can happen in a normal stool or with diarrhea or constipation or with someone that has an inflammatory condition. Frank red blood would be on the surface of the stool, and that usually comes from some lesion in the rectum or the anal canal. It could be like a varicose or a dilated vein there, or some sort of hemorrhoid. This blood is frank red because it has not been digested yet. Occult blood is a small amount of hidden blood. You cannot see it with your eyes, but if we do like a GUIAC or occult blood test, we'll be able to pick it up. Occult blood is usually caused by small bleeding ulcers in the stomach or the small intestines. Melena is a dark colored tarred stool. That typically comes from bleeding that's higher up in the digestive tract. Intestinal bacteria have already acted on the hemoglobin, causing that dark black color. Gas develops normally when we swallow air, also from digestive and bacterial action that's taken on the foods that we eat. Certain foods or alterations in motility can promote gas production. Excessive gas will manifest itself as belching or expulsion through the mouth, abdominal distension, and discomfort or flatus, expulsion through the anus. Irritation is the oral ejection of gas or air from the stomach, known as belching. Borborygmus is the rumbling or gurgling sounds that we hear when there's gas in the intestines. So when you're doing your bowel sounds, you'll hear this rumbling. That is gas in those intestines. Constipation is when there are less frequent bowel movements than normal and small, hard stools result. This can vary for everybody, okay? Not everybody poops every day. Some people, their norm is a couple times a week. Some people might only go once a week. So you really have to know what their norm is to determine the constipation. And they usually have signs if they're constipated. It can be acute or chronic. In some clients, it can alternate with diarrhea, so they may have constipation, diarrhea. Emptying of the bowel with diarrhea can lead to decreased peristalsis and an increased time needed for reabsorption of fluid. So that can cause the feces to be hard, dry. The dry feces will irritate the intestinal mucosa and cause it to become inflamed and increase secretions. Once the hard feces have been expelled, diarrhea can follow. Chronic constipation can cause development of hemorrhoids, diverticulitis. Now, diverticulitis, you're going to roaches in the intestines, and foods can get stuck in there, like anything with seeds, popcorn, beans, small beans, uh, corn, nuts. Severe constipation can cause fecal impaction or retention of feces in the rectum and the colon. Or intestinal obstruction manifested by pain and abdominal distension. Watery diarrhea masks fecal impactions because the fluid pushes past prolonged fecal. So sometimes when someone's constipated, you'll have diarrhea or fluid leaking around that stool and coming out. Causes of constipation are going to be weak muscles because of age or illness, inadequate fiber intake, causing less bulk in the intestine and decreased peristalsis. A lot with your older adults because guess what? I don't have to eat my vegetables anymore. I'm grown, and no one's going to make me. And a lot of times, in addition to that, they're eating full course meals because they're by themselves, they're alone. So don't put that again soup or eat something else for dinner besides a full meal, and they're not really taking in that fiber in any manner. Inadequate fluid intake, failure to respond to defecation. So another thing, inadequate fluid intake with the older adults, the fluids that they do take in are diuretics mostly. They don't drink water. So most of them are drinking coffee or alcohol or sodas, okay? And those things are all going to cause fluid to leave the body. They have to be drinking water or something that has, some sort of concentration to help you absorb fluids. Everything else that mostly they drink are diuretic. So they're not taking in enough fluid a lot of times. And people will withhold fluid from them because they're incontinent, thinking that's going to make it better. And it's not. So don't allow somebody to be lazy and do that, withhold fluids from somebody, because that is only going to make more problems. It's not going to help with the incontinence. It'll probably make it worse. Failure to respond to defecation reflex. So again, let's say that I'm coming from home, I fractured my hip, and now you put me in a room with someone else. I don't know about y'all, but when I go to the bathroom, I don't want nobody else around. You like to be in your private little spot, and that's where you like to go. And honestly, you're inconvenienced or upset when you're out and you got to go somewhere in public, even if it's a public bathroom. Because you don't want nobody sitting next to you. You just like that quiet space. Immobility, if they're not moving around. Again, that can cause muscle weakness. Neurological disorders like multiple sclerosis or some sort of spinal cord injury. Taking opioids or narcotics or other central nervous system depressants. or anticholinergics, because you know the saying for that, right? Can't see, can't pee, can't spit, can't. They block the peripheral nervous system, anticholinergics, and that slows down peristalsis. Some of your antacids, your iron medications, and your bulk laxatives. Obstruction because of tumors or strictures. You can also end up with fluid and electrolyte imbalances. Dehydration, hypovolemia are common complications from the digestive tract involved with some disorder. When vomiting and diarrhea occur with a lack of proper fluid intake, the fluid will shift from the blood into the digestive tract. So sometimes when people have vomiting and diarrhea, they don't want to drink. And they especially don't want to drink water. Okay. So that can cause, they're not taking any fluid in, they're giving fluids out. So it can cause that fluid shift or that change. If prolonged intracellular fluid is decreased by hypovolemia with impaired circulation and cellular dehydration, which can decrease function in all tissues and organs. So we're like in a shock situation where your body is not getting enough fluid at all. You don't have enough in there. Your circulation is impaired. You're dehydrated. Okay. You can end up in multiple organ failure. Okay. Infants and elderly persons are particularly vulnerable because of water to body ratios. So with the babies and the older adults, and I would know this, they have a decreased ability for the kidney to compensate quickly for any losses. Sodium also lost in vomiting and diarrhea. Gastric secretions high in chloride are in that stomach. Okay, so when you vomit, that acid, that hydrochloric acid is going to come out, and that can cause you to become metabolic alkalosis or to develop metabolic alkalosis. So in that case, you're losing hydrogen ions, you're losing that chloric acid, and you have an increase in the bicarb levels. And all those lead to alkalosis. Diarrhea leads to significant losses of potassium out your asium, and that can lead to metabolic acidosis. If vomiting is severe, there's a change to metabolic acidosis. Duodenal secretions contain large amounts of bicarb, which are lost. Ketoacidosis develops because you lack glucose, and lactic acid can accumulate as a result of hypovolemia and impaired tissue perfusion. You can also have an increase in muscle activity here, and together these all will lead to acidosis. Visceral pain fibers are connected to the autonomic nervous system. Autonomic responses like pallor and sweating or nausea and vomiting can occur with this type of pain. The following types of visceral pain arise from organs in the digestive system. You better know these, okay? So with ulcers, you're going to have a burning sensation with inflammation and ulceration in the upper digestive tract. You can also have ulcers in the mouth or heartburn from the gastric erosion of that esophagus. A dull or aching pain in the right upper quadrant of the abdomen. That's usually caused by swelling of the liver because of the liver capsule. Cramping or diffuse pain, characteristic of inflammation, distension, or stretching of the intestines. And this one here is the one they love to test about. Colicky pain. Colicky pain is severe pain that comes from recurrent smooth muscle responses. So usually there's some sort of obstruction there, like a stone, and the body's trying to get rid of it, like a gallstone. And that causes that colicky pain, that severe pain. Better know that one. There are somatic pain receptors directly linked to your spinal nerves. Not a new concept for you. You've heard about this. Okay, these can cause a reflex spasm of the abdominal muscles, causing a rigid abdomen or guarding. Somatic pain is characterized by a steady, intense, well localized abdominal pain. And it usually indicates involvement or inflammation of the parietal peritoneum. The parietal peritoneum has numerous pain receptors. That forms the basis for rebound tenderness over an area of inflammation. So, like when people have acute appendicitis, usually they'll have this rebound tenderness. So you'll go like between the iliac crest and the belly button, and you'll press down really deep with a couple of fingers, and you'll let go. And the pain will be experienced when you let go. Usually we know with that person that they have appendicitis. Referred pain is pain that's perceived as a site away from its origin. So you'll see this in things like pancreatitis. Referred pain is when pain from one part of your body is felt somewhere else. For example, pancreatitis could cause pain in your back, or a heart attack could trigger pain in your jaw or your left arm. It happens when visceral and somatic nerves come together at one spinal cord level, and the source of the visceral pain is perceived as the same as that of the somatic. All right, so this is just showing you some examples of referred pain. Usually with pancreatitis too, they'll lie in a fetal position. They can't lie on their back. It's very painful. Depakote is a big cause of this. So if you guys have clients on liquid Depakote, especially, any Depakote can cause it. Please pay attention to them for this. They don't advertise it, but it's there. Malnutrition. So a nutritional deficit could be limited or general, and it could be caused because of GI function issues. You may have a specific problem like a B12 deficiency, which is directly linked to the lack of that intrinsic factor. Malabsorption, liver damage, or a bleeding ulcer can lead to things like iron deficiency. General malnutrition can be caused from chronic anorexia, vomiting, diarrhea. This can be caused by some sort of GI dysfunction or other systemic problems. For example, chronic inflammatory bowel disorders can cause anorexia, diarrhea, malabsorption, or vomiting and diarrhea can be related to something external like a cancer treatment, radiation, or chemo. Wasting syndrome or chronic diarrhea is what we see in clients that have AIDS, and it causes them to have malnutrition and dehydration. Interference with bile or pancreatic secretions because of the mucus plugs in someone with cystic fibrosis is another example of disease that can cause malabsorption and malnutrition. Some special diets or fad diets can cause a lack of required elements for proper balance of nutrition. So, like your keto diets, where people just eat high proteins and fat, and that's all they eat. Okay. That can cause a problem. There's a lot of other fad diets out there too. The soup diet. Now they have the diets, the Monjero diet. Okay. And even those shots that they're giving people. Okay. I wouldn't take them to lose weight. Get your ass out there and exercise. You want to lose weight. Okay. Because all these things have side effects. And honestly, if I showed you a picture of my sister who takes those shots, she's younger than me. Somebody saw her on the street the other day and thought it was my mom. My mom is almost 90 years old. Look at people that are taking those shots over long term. Because the way they're losing the weight is not healthy. There is nothing out there that causes you to lose weight that is going to be healthy or good for you. And it can cause other issues long term. No one knows what those issues are going to be. And people just jump out there. Oh, they said I can lose weight. Myself up. Be cautious with what you engage in. You get what you sign up for. There's an old saying, you get what you sign up for. And it's going to affect the way your body is because it's not naturally losing the weight. You're not doing natural things, healthy things. And some of them still eat very unhealthy, but they take the shot every day. Well, I take the shot. I'm good. Meanwhile, they're eating a tasty cake and a Pepsi and taking the shot every day. So how do you think that's going to affect your body over time? There are 8 essential amino acids that are required simultaneously in the body, and they're present in animals. If someone eats a vegetarian diet, you have to make sure that they're incorporating those amino acids into the diet. In children, growth and development can be delayed or impaired from absorption and malnutrition. And you'll see this in some kids because they have diseases that cause this. One of them is the short bowel or the dumping syndrome. When someone has malnutrition, they're going to suffer with fatigue, reduced resistance to infections, and impaired healing. Now, obesity occurs when the energy value of the food consumed is greater than what the body needs. So a BMI of 30, greater than 30, is indicative of obesity. This is often seen in people that don't include fresh fruits or vegetables in the diet. Complications are going to be things like hypertension, atherosclerosis, type 2 diabetes, obstructive sleep apnea, arthritis, and congestive heart failure. So there are a few disorders of the upper GI tract. It can include the oral cavity, dysphagia, esophageal cancer, hiatal hernias, GERD, gastritis, peptic ulcer, gastric cancer, dumping syndrome, which they also might refer to as short bowel syndrome, and pyloric stenosis. So with the oral cavity, some of these are congenital, like cleft lip and cleft palate, and they develop in the mouth and the face. Okay, during the second or third month of gestation, the cleft lip and the cleft palate seem to be multifactorial in origin, meaning there's multiple things that cause it. They're related to a number of inherited and environmental factors. They may have one or both. The cleft lip, you have to know these. Maybe unilateral, so it can happen on one side or both sides of the midline. And what happens here is we have failure of the maxillary process to fuse nasal elevations, failure of the upper lip to fuse. Now, the lips form between weeks 4 and 8 of fetal development. Okay, so the tissue should join together at the face, make the lips. The cleft lip happens when those tissues don't make the lips or don't join completely together. These kids end up with an opening or a gap between the two sides of the upper lip. Cleft can range from a small indentation to a large gap that reaches the nose. Cleft palate itself involves failure of the hard and soft palates to fuse, usually between 7 and 12 weeks of gestation. This causes an opening between the oral cavity and the nasal cavity. The cleft palate is a split or an opening in the roof at the top of your mouth. It can include the hard palate, which is the bony front portion of the top of the mouth, or the soft palate, which is that soft area towards the back of your mouth in the top. These babies cannot eat properly because they don't have enough force to either suck or because they aspirate fluid through that hole and it goes into the respiratory system and they aspirate. It also can affect their speech. They're going to need some sort of surgery and also plastic surgery, probably. All right, so that's just a picture of it. Other things that you can develop in the mouth, abscess, ulcers, or you might hear this referred to as stomatitis, canker sores. These are little small ulcers on the mucosa, the buccomucosa, the floor of the mouth, the soft palate, the side borders. You'll have ulceration that's punched out with a white appearance, surrounded by a red border. Okay, so your grandma might tell you that you've been telling lies. How many of you heard that? Your grandma tell you them little white sores in your mouth are from telling lies.
Yeah, used to call them lie bumps.
Yep. The oral cavity has large and varied resident flora, and those microorganisms love to live in those dark places in your mouth. There is Streptococcus sanguinis. This is a bacteria that is present in the mouth, and it's very present, very abundant. And it can cause those sores or those ulcers to develop. They're also part of the viridins streptococci. So we talked about this. These can cause sometimes problems, people, especially if they're immunosuppressed. The ulcers usually heal right away in about a week or so on their own. Other bacteria that lives in the mouth or that might be in the mouth, viruses, these can have opportunistic infections like candidiasis or that yeast infection, especially if there's open sores in the mouth. Candile infections may look red, swollen. They might look like patches of white curd-like material. Candidiasis or thrush is a common fungal infection, and it usually happens in people that have like broad spectrum antibiotics for a long time, like Vaco. If they're on chemotherapy, if they take a lot of steroids, people that are diabetics, people that are immunosuppressed. And this thrush can go all the way down into your esophagus. So usually they'll be on nystatin, and you know if it's in the esophagus or not, okay? Because they'll either have them swish and spit, or they'll have them swish and swallow. Swishing and swallowing, that esophagus is infected as well. So agents are Candida albicans. These are part of your normal flora. And somebody immunosuppressed can cause an opportunistic infection. Okay. And it happens in people after they've been taking broad spectrum antibiotics, maybe after they've had chemo, or they're immunocompromised for a reason. And they're going to look red, swollen, white, curdled. There's a picture of it. All right, herpes simplex also is going to usually happen in the mouth, in other places, but we're talking about the mouth here. Herpetic stomatitis, so it's going to be those cold sores, those fever blisters. Oh, this is the gift that keeps on giving. Okay, most of the time, if you have this, you got it from your parents, or you got it from your boyfriend, so you're going to give it to your kids if you have kids. It's caused by herpes simplex 1, type 1, and it's transmitted by kissing or close contact, typically in childhood. All right, people laying them big sloppy kisses on you. The initial infection is usually going to be asymptomatic. The virus stays dormant in the body. It stays in the trigeminal nerve, the ganglion. I would know that. When it's activated, and when are you going to get these cold sores or these fever blisters? When you're going to the prom, when you have a big event like a wedding, right? Now you're trying to put your makeup on and you got this big, ugly sore on your mouth. So you're under stress or trauma or another infection like a cold. The virus migrates along the nerve, that trigeminal nerve, that sensory nerve, to the skin of the mucosa. First, it starts with a burning or a tingling or stinging. And then you get these little vesicles or the blister itself. When the vessel ruptures, it leaves a little ulcer, just pure phlegm. Now, these lesions will heal, but guess what? That saliva still has the herpes in it. Okay? The lesion will heal about 7 to 10 days. And when the virus migrates along that trigeminal nerve back to the sensory ganglion, it'll enter that latent stage. Reoccurrences are common here. In immunosuppressed patients, they can develop lesions in the oral cavity and the pharynx. HSV1 is often present in the saliva for some time after the vesicle is healed. Vesicle, okay, that doesn't mean the person's not contagious. All right, I'm going to stop there. That is slide 60, okay? This hepatic whitlow, let me just talk about that real quick. People, okay? Look at that picture of the finger. So somebody had herpes, dental person didn't have on gloves, stuck their finger in the mouth without an infection. Also, the herpes can spread, okay? It can spread to the eyes, causing conjunctivitis or keratitis, which we talked about when we did the eyes. We have the infection in the cornea from the herpes. Okay, that's it now for sure. Tomorrow, that's with syphilis, okay? That's where they'll start the lecture from. So hopefully between tomorrow and Friday, you guys will get the rest of that lecture. And the lecture is on YouTube. There is a Jeopardy game for it. If you can't find the Jeopardy game, let me know. And we also have any questions.
Ms.
When
Lois,
did
did
you
you get
get
my
the
message?
text two grades? The grades.
So evening didn't take the test yet. And tomorrow we'll probably have a pod to review the exam. So I wouldn't expect to see the grades before Monday. Get the grades, I'll put them in and ask the team to release them.
You're
Release them.
muffled, Ms. Loesch.
Hello?
Yeah, you
Can
gotta
you hear me?
repeat the whole message because we ain't hear you.
Okay. So evening class did not take their exam yet. They take their exam tonight. So tomorrow we have a pod. We'll discuss the test and grades. I wouldn't expect to see the grades before Monday. If they come to me on Friday, I will get them in and I will ask the team to release them. But I wouldn't expect to see them until Monday.
Okay, thank you.
All right.
Ms. Loesch, did you get my message?
If it's in the chat box, no.
It's privately sent to you.
Let me see. Who is this?
Tasha.
Okay, yeah, stay on.
Okay.
Can you send out the Jeopardy?
Yeah, I'll send out the Jeopardy.
All right, thank you.
All right, Tasha, let me stop my recording first of all. And then I'll make sure everybody else is out of the room. The only other person that's going to be on here is Miss Morgan because her and I have other stuff to do after this.